what are some common challenges that flight crews face when picking up patients from the hospital? And are there things that we as nurses can do to make that process smoother? So I'll rephrase the question. What have you seen us do wrong that we can do better so that we don't make the same mistakes that some other nurse made? That's what I really want to know.
I could go on some tangents for real.
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life.
All right. Welcome back to the Rapid Response RN podcast. Today, I have joining with me Sam, who is a flight medic and the host of the Noon podcast. Sam, welcome to the podcast.
Thank you so much for having me on today, Sarah. I really appreciate it. I love your energy.
Thank you. Well, I'm very excited to talk to you today because I feel like this is an important topic. There is so much mystery and question around the flight world. And I hope you can kind of speak to what actually goes down. And also, the thing I'm hoping to cover today is I want to break down the silos between our two worlds of pre-hospital and in-hospital. They are different, but they are similar, and we are on the same team. So let's talk about how we can collaborate. Okay, so before we dive into those specifics, can you just talk about, first off, like, your career, your role as a flight medic, what led you to this. And at the end, we'll talk about your podcast. But for now, let's just talk about flight medicine. Okay, so how did you get into being a paramedic? Why flight paramedic? And then how is it different? Like what drew you to it versus working on the ground?
Sounds great. And those are all great questions. So I've been in EMS for going on 20 years. I started out as an EMT basic, progressed up to an intermediate for 3 years, and then became a paramedic. That was my overall goal at the time, was just be a paramedic. I really didn't have any draw towards flight. For other EMS people that are listening or first responders that are listening, flight is kind of like the high-end goal for paramedics. That's where we want to be. It's prestigious, right? It's critical care. Mm-hmm. That means you know what you're doing and you're basically going to the full limit of your scope of practice, which is where everybody wants to be. And it is amazing. Flight for me really wasn't an option until I got out of working on the ambulance. I actually worked in the ER for a few years and saw a different side of medicine that kind of started pushing me towards critical care. And I love the critical care aspect of being a flight paramedic. It's really opened up a lot of avenues that I didn't necessarily get to see working in the ambulance, it's been a really cool experience. I've been doing it now for about 6 years.
That's awesome. How would you say that your role has shifted going from ground paramedic to flight paramedic? Is there a different scope of practice, different patient populations, different role?
Yeah, definitely an increased scope of practice. The biggest thing for paramedics is in a flight role is getting to do an RSI, so a rapid sequence intubation, actually getting to put people to sleep, basically paralyze them and then intubate them. And that's something you can't do on the ground in very many places. There are some places that have that as a special skill, but flight's kind of where it's at there. There's a couple of other special skills that we can do, finger thoracotomies as well. Outside of that, it's really like getting the knowledge and understanding a much deeper pathophysiology, right? And understanding the mechanisms of the medications that we're giving and the things that we get to do. As far as population-wise, it didn't really change populations for me. We can still see anybody from newborn up until, the hundreds if they make it that far. So there's not really any specialized populations as far as age goes. The cool thing with being in flight is that you get to not only be where you are locally, you actually get to travel in various states. So nurses have the compact license. Paramedics have what's called an NREMT license, a nationally registered EMT license. And while that is recognized in a lot of states, it's not really recognized, if that makes sense. So I still had to go out and get my license for Arizona, Colorado, and Texas. So I'm licensed in my 4 surrounding states.
Gotcha. Well, that's exciting. So you've actually had the opportunity to work ground, flight, and you said you worked in a hospital as well. What would you say are some of like the biggest differences between pre-hospital care and in-hospital care that you've maybe noticed either while you were working in those different places or like while you're transferring patients between the environments? What do you think are the biggest differences?
I mean, I think when you work on the ground, it's really easy to say like, man, those nurses didn't care. Those doctors don't care. They don't know what we dealt with. My mindset really changed once you got into working in the ER because you really got to see what happens. So much shit as we talk, being pre-hospital providers, there's just as much shit being talked in the ER. Like, man, those guys don't know what they're doing. But really, like, if it came together and collaborated a little more efficiently, we could take over the world, really. Like,
yes,
getting to see the long-term medicine and the short-term medicine, if we could collaborate and get into training together, we really could change a lot of the systems that we have in set up right now.
Yeah, I agree. I mean, that's how we provide the best care, right?
Yes.
Interdisciplinary collaboration, like, I have some great ideas, but sometimes I miss stuff.
Yes.
And your perspective is a whole other perspective on patient care. You have a whole other like knowledge set of how to respond to emergencies. So I'll just say, I've noticed some of that in rapid response. Like as an ER nurse, the patient was often just kind of delivered to me. Whereas in rapid response, I show up and they're like stuck between the toilet and the bathtub. Or, there's situations that I'm not prepared for from nursing school, like I'm used to just like how to resuscitate a patient in a bed. But what about whenever they're like on the floor, upside down, like prone? What do you do then, right? These are things that you face all the time. No big deal. Like, let's go to the trailer and we're going to go in the back room that's covered in cats. And like, I don't even know, like there's all these different challenges you have to just like overcome to get to your patient. So yes, let's tap into each other's resources and knowledge base to support these patients. So I wanted to ask this specific question. What are some common challenges that flight crews face when picking up patients from the hospital? And are there things that we as nurses can do to make that process smoother? So I'll rephrase the question. What have you seen us do wrong that we can do better so that we don't make the same mistakes that some other nurse made? That's what I really want to know.
I could go on some tangents for real.
Your tangents are welcome here. Tell us all the tangents, Sam.
I will say that for the most part, the transitions of picking up are pretty easy. One of the common misconceptions that we can get in flight is that every call we pick up is going to be a critical care flight. That is not accurate. So our smoothest transitions are when it's not a critical care flight, right? So like you're going in for just a regular patient with a minimal complaint. We still fly all of that. That's normal. I would say critical care, at least in my setting, is probably 25 to 30% of our call volume. That can still be pretty high at times, but for the most part, it's really pretty average patients. Still sick, right? Just not critical care sick. But when you have a sick patient, especially in hospitals that are very small, very remote, they will see the flight crew walk in and be like, I'm done. Okay, see you later. Have fun with this patient. Like the care at that point has then stopped from a lot of those providers. And that can be a little frustrating when you're walking into literally just a shit show. And like, I get that you're in a rural area and I get that maybe it's super busy at that time. I'm going to give you an example right now. We went out to a really small department. I mean, like 10 beds in this ER. And we were going for a post-ROSC patient. For people that are listening and don't know, that patient coded, right? So their heart stopped. They did CPR and they were able to get pulses back. This patient was sick, super sick, 3 or 4 different pressors, intubated. We walk in and this patient is like, you've paced a patient before, right? You know what that looks like.
Oh, yeah. It looks very uncomfortable. Mm-hmm.
Jumping off the bed, basically. Or they look kind of like they're seizing.
Yeah.
So they had paced this patient for a little while. This patient was still actively being paced. And I looked at the nurse and I said, are you guys pacing this patient? He said, no, we stopped pacing this patient like 3 hours ago. I said, does this patient have seizures? He was like, no history of seizures. I said, then you're probably pacing your patient. And I walk over and they had the patient connected to not just the wall computer for vital signs, but they also had the patient connected to their life pack or Zola. I don't remember what it was at bedside. And they had been actively pacing this post-ROSC patient for about 3 hours.
Oh, man.
And it stuck like that. We're like, I know you called for flight and I know like, this is a handful, right? You're calling for flight. There's a necessity for flight. This patient needs to go to a higher level of care. Don't stop caring for your patient just because we're coming. Mm-hmm. That's probably one of my biggest peeves.
Yeah.
And providers that are afraid to treat patients, essentially, like patients that need to be paced because they've got a heart block, a third-degree heart block, and they've given atropine 4 or 5 times, and it's not done anything, but they decided the patient can get paced when they make it to the other facility. No, this patient's about to code. Like, you need to pace now.
Okay, so your takeaway message would be, don't be afraid to do the high-risk intervention, or like what's it called? High risk, low volume, like those kind of things. Like,
yes.
Okay, I mean, for me, those aren't that low volume. I pace patients all the time. But I guess if you're not often seeing critically ill patients, you probably, turn the life pack or the Zol to pace a road in a bit. Yeah, don't delay the patient's care that's needed just because it's something that you haven't done in a long time.
Yes.
And then the other one you're saying is once the team is coming or once you show up, not just be like, all right, sweet, I'm out. They got this. You probably still need their help, right? What are some things that you need them to be doing to support you? Or like some examples of things maybe they can do that would be helpful whenever you show up?
And the biggest thing, is that we're always going to need paperwork. It's no different. Like if you are going to transfer this patient out, we need paperwork, and we don't just need a face sheet. We have very specific physician certification statements. We also have a few other forms of paperwork that we need. And I think hospitals tend to forget that as well. And they get upset when you're asking them for that paperwork. I still need a full report from you for this patient. We're only going to have this patient a half an hour, longest time I've had in an airplane is probably about 4 hours. Mm-hmm. So between half an hour and 4 hours, like that is my time. All of the information that you can give me helps save me time from having to dig through every piece of paper to figure out what medications you've given, what interventions you've done, any tests that you guys have ordered, what the results of those tests are, and how the labs look, right? So being knowledgeable on that patient, the things that you've done for that patient, even if you've just taken over this patient at shift change at 7 and it's now 7:15, would be super grateful, because I'm sure we're not just showing up surprising you, right? Like there is knowledge that we are coming. And if the previous nurse is able to provide like an S-bar or something else like that for the next nurse, even more helpful.
So a good S-bar for like what led into this event, what you've done so far. Here's the paperwork showing what we've done so far. I've done actually 6 ride-alongs with flight crews in my area just because I was kind of considering that as a career path, mainly because everyone told me you'd be a great flight nurse,
Yes.
So I did a bunch of ride-alongs to try it out. And one thing that I saw that was surprising to me, I just always thought, okay, the team's going to show up, load them up and get out of there, right? Like your goal is to get to the facility that has the intervention this patient needs and just get them out of there. But every time I was eventually I wasn't surprised. I kind of knew why, but the team would show up to the smaller hospital and they would like optimize first. So they're going to get an ABG. They're going to change the settings on the ventilator. They're going to titrate the drips. They're going to titrate this one off. They're going to start this new one. Like they made a bunch of changes so this patient was as stable as they possibly could be before they loaded up in the helicopter and went thousands of miles in the air, 100, I don't even know. However high you go in the air with this patient, they wanted to optimize them first. And I was like, okay, that actually makes sense. It's not as like cool and sexy, but load them up and we're out of here. See you guys. Like there was one time we were there for like an hour stabilizing before we actually transfer the patient.
Mm-hmm.
But I'll tell you what, I felt much more comfortable being in the air with this patient when they weren't bucking the vent and like not sedated and they're hemodynamically like wackadoo. Like we got them totally chill and then we loaded up. And I was like, okay, this was a great idea, guys. I like your thinking here. So yes, that is a little different, I think, a misconception that maybe us nurses have about what the role of the flight team is. They're not just going to come get the patient off your hands right away. They're going to kind of optimize first.
Yeah.
So then the question is, what can we do as a bedside team to help with this optimization? Like sometimes it is getting the medications that are needed and maybe getting equipment that's needed or different tubings or connections or like things to help optimize this patient. The other thing I saw, and I just need to go on this little tangent here, Sam, because it drives me crazy. I saw this multiple times in my whopping 6 shifts following a flight team. We would show up, the patient's blood pressure had been low, and so the facility that was sitting to the patient had not started sedation because they're like, the patient's blood pressure is too low. They can't have sedation. They can't have analgesics. Their blood pressure is too low. To which I'm like, then start a vasopressor and treat your patient appropriately.
Yes. How do we fix that?
Yes, of course they're bucking the vent because they don't feel good. Like they're scared and they're in pain. And like, yes, as that's one thing I saw is like, yes, we're just going to titrate up the vasopressor and so that we can get the sedation on. I had another patient that we showed up to. It was pretty soon after ROSC. And I guess they had given RSI, including a paralytic, to get the patient down, but then they never started sedation. So this patient's blood pressure was like through the roof, tachycardic in the 140s. They're like, I don't know, he just keeps getting more and more tachycardic and more hypertensive. But the guy's laying there looking cool as a cucumber, even though he's like diaphoretic because he's paralyzed and wide awake. Yeah, so immediately the flight medic that I was shadowing, busted out some etomidate and just pushed it in the patient to like sedate him. And then we got the medications on board to keep that state of calm and sedation for this poor patient that we're about to load up into a helicopter.
That's probably more common than you would like to.
I know. It's heartbreaking.
It's common. Yeah, it is heartbreaking.
And like, I understand the thought process. Initially, they're like, yeah, we want to make sure we have perfusion. We got to have a blood pressure. This is going to drop the blood pressure. But we have things to fix blood pressure if you're just willing to, utilize it. There's so many vasopressors that we could use to get this patient's blood pressure maintained. We can get fluids to the patient. There's so many options. But the option of not starting sedation on someone who's paralyzed should never be on the table. That is a never event.
That's terrible medicine. One of the other big misconceptions, too, is that when you have a patient in the ICU, you want like a RAS score of, -2, -1. This patient's not going to be heavily sedated. My goal as a flight paramedic and my team as a flight team, you're going to be knocked out, right? Because we might hit turbulence. We might have some wind. We're going to get rocked. We don't want this patient to be waking up in the middle of this flight because that's terrible. That's terrifying to wake up to.
Yeah.
So we'll make sure that we try to make sure that they have a RAS of -4, at least for the duration of the flight.
Yeah. And that makes sense. I mean, like in the ICU setting, we actually want the patient to be somewhat awake to participate in their care so we can communicate with them and like optimize them as far as like mobility. But you do not want mobile patients in your unit.
No.
You want your patients to be very calm, still on the stretcher because you are, how high are you in there? I have no conception for like how high this, are we talking hundreds, thousands of?
So it depends. If you're in a helicopter, you could be 100 to low, couple of thousand feet.
Okay.
In an airplane, so like the threshold for a helicopter that doesn't provide oxygen, if it's not a closed cabin, right, is going to be about 10,000. That's the max. Most of them aren't going to fly that high unless they're going over a mountain or they're clearing some other obstacle. In an airplane, however, depending on distance that you're going and the size of the aircraft, you could go anywhere between 10 and like 25, 30,000 feet.
Okay.
So it's pretty hot.
Yeah. So that's a lot of feet in the air to have someone who's like wilding out and not sedated.
Yes.
This is not the time to like have your patient awake and fully communicating with you. It's okay for them to be chilling during the turbulence. Yeah, exactly. Are there any things that you feel like misconceptions maybe, or things that you wish people knew about your capabilities that you have or don't have in air as far as like scope of practice or what resources you do or don't have access to?
There's a couple. Like, really, we have a pretty broad scope here to the extent that some providers, some flight companies can even transport like huge pumps, right? Like cardiac pumps, that kind of stuff. But I think one of the biggest issues that we have, especially locally where I'm at, is psych patients and what we should do with psych patients. Because we're so short on ground services, there's been a huge utilization of flight services for psych patients in the last few years. And one of the issues, again, I can only speak for the facilities that I know locally, they don't provide the psych meds that those patients need, right? They're all about sedating and knocking this patient out if they're wigging out, but they don't give them the maintenance medications that they might need for the psychiatric problems that they have. So there's a lot of people getting upset when we respond to pick up a patient to fly to a psychiatric hospital and they're wigging out and we don't take them. Mm-hmm. That is a huge safety risk. And they're like, well, why don't you just strap them down in the airplane? Well, the problem is, what happens if that strap comes loose and I don't have time to drop that medication and give that to that patient before they've now gotten out, knocked out myself, knocked out my partner, and are going for our pilots, right? So that is a huge misconception here locally where I'm from. Wow. But really everything else there's not very many limits other than space and time in the aircrafts in which we're transporting. Mm-hmm. Obviously, I don't know if you flew in a helicopter or a fixed wing, but it's tight, right? It can be really tight in there, but some of the aircrafts can actually transport a lot of the bigger machines that the patient might necessitate.
So what about things like supplies? Like, how many bags of norepinephrine do you have on board? Like, how many units of blood are you going to be able to deliver to this trauma patient? Like, what is the end? Because I can just go to the blood bank and get more. I can just go to the pharmacy and grab more. Like, what point do you run out? Have you ever run out of supplies for a patient?
Quick pause. I've got a question for you. Have you ever walked away from resuscitation thinking, that went pretty well, but how can we be even better next time? Well, I hope you've asked that because that's how we keep getting better and better as clinicians and as teams. Let me tell you about another great podcast that you need to check out. In the Heart of Care is produced by RQI Partners and hosted by Dr. Ash Panchal. You may remember him from episode 140. He's an emergency physician and educator who really understands what it takes to lead when the pressure's on. This show takes you inside the real work of building readiness, what systems and strategies actually hold up during critical events, and how teams train, communicate, and grow from both wins and missteps. You'll hear honest stories from the front lines, lessons from sim labs, and practical tools that can help your team perform better when it matters the most. So whether you're at the bedside, running education, or leading a team, there's something in every episode for you. In the Heart of Care is available now, wherever you get your podcast. Give it a listen. Now, back to the episode.
That's such a great question. I am never afraid to ask for supplies from the hospital. I know that a lot of newer people coming in, they're like, oh, but we carry this stuff. Yeah, but we're limited. So if we pick up a patient going from Albuquerque to Phoenix, right? And we've utilized all of the medications that we have, the 1 or 2 bags of Levophed that we carry. Obviously, we can't reuse that. So now we've wiped out our whole bag's worth. If there's another call, say going from Phoenix back to Albuquerque or going some other rural city in New Mexico that also needs to go back to Phoenix, we can't necessarily take them because we don't have that backup supplies. So I am not afraid to take as many resources as I can from the hospital.
Gotcha.
Which could be a lot.
Yeah. Like, I'm going to need one for the road.
Yeah.
For the air. I'm going to need one for the air.
Yeah. I do try to do calculations. I don't want to waste. So I do try and I do some med math at bedside. Like, if we're taking a bag of norepi and we're taking a bag of dobutamine, we're taking a bag of vasopressin, like, I'll try and do the math and get just enough to get us to the other facility with a little bit of spare time just in case there's a delay in ground transport. Or there's weather that we're hitting and we end up having like a headwind or something. We can't go as fast as we normally would. So I do try not to be wasteful.
And you have to balance okay, I would love to take all the things, but there's only so much space in this little helicopter. So I can't take everything. Like, what's the most important stuff that I might actually encounter that I'm going to need for this particular trip? Yeah.
Yes.
Exactly. Okay. So whenever you arrive at the facility, what does the ideal handoff look like? Teach us the way to do it with perfection.
The ideal handoff for me is walking into the patient's room because I want eyes on the patient. That's my very first thing. And the patient, the RN handing me, or tech or whoever's taking responsibility of this patient, handing me a packet and then giving me a report. Hopefully everything is done. Like, again, I get that people can be busy, but sometimes if those patients have been sitting there a while, they might need to be changed. Their fluids might need to be replaced. Whatever, you know what I mean? Having that patient packaged and ready to go is super helpful. On critical care calls, you now understand also, like, sometimes you're going to walk in and it's not going to be just put them on the bed and get going. No, I really like to take my time, like you said, to optimize this patient to be ready for transport, because it's not just moving them from bed to bed. We now also have to consider flight physiology. So we're thinking about how the air is going to be impacting this patient. Is it going to cause any inflation in their belly? Any swelling in their brain or their lungs. So those are things that we also have to start considering. So I think the most ideal handoff for somebody who's not critical care would be just a really good report, that packet being ready for us, and the patient being packaged and ready to go. Cleaned up, warm blankets, pillow if you can spare the pillows, blankets if you can spare the blankets, because it tends to get really cold.
Yeah.
Once you start getting into the air, it gets really, really cold. And the heaters aren't always the best in the airplanes.
Gotcha.
That being said, the ACs aren't always the best in the airplanes either. And in some helicopters, they don't have either heating or air conditioning.
Oh, gosh. Yeah, and your flight suits, I actually wore one. There's a whole story behind that. But they are both really hot and also freezing cold. Like, they don't insulate very well, but they also make you feel ridiculously hot in the summer. It's like the worst of both worlds. So here's my time that I wore a flight suit. I've never been a flight nurse, for the record, but I went for a ride along one day, and they were doing this PR event where some parking lot, they had the helicopter land and the ambulance and the fire truck and the garbage truck. There was just a bunch of community cool vehicle mode of transportation that were parked there. And so all the community came out, and there was kids. So they were doing this event. And I was like, oh my gosh, that's awesome. I'm so glad I'm here today. I love kids. And the flight nurse and the flight medic and the pilot were like, oh God, we hate these things. We have to do them a couple times a month. We hate them. I was like, are you kidding me? This is going to be a blast. So we're literally just going to show people how cool the helicopter is and just take pictures with little kids. This would be awesome. It's you know what? You're the same size as Jen. You need to wear Jen's flight suit and you can talk to these people. I was like, no, I'm not a flight nurse. They're like, oh no, you're doing it. They called Jen. Jen, hey, we have this girl, Sarah, here. Can she wear your flight suit? They're like, oh, she's like, sure, go ahead. So I put on Jen's flight suit. We show up at this little small town for this PR event. And the three of them are just hanging out in the back, just watching me work the crowd. Come on over, let's get a picture. Let's put you up by here. Everybody in. And everyone's starting to talk about what's it like being a flight nurse. And I'm like, oh, I love being a nurse. I just deflect. But I had such a good time.
That's awesome.
Posing as a flight nurse for the day. If they had specific questions that I had no idea, which there were a couple of those, I'm like, oh, actually, these guys have been doing it a lot longer than me. Which is very true because I had not been doing it for any time whatsoever. Anyways, I said all that to say that flight suit was so uncomfortable. When we were in the air, I was freezing cold. When we got to the ground, I was burning up. They look really cool. They are so badass with all the pockets and the zippers, but they are not comfortable. Even though they look like they would be, they are not. Just wanted to throw that out there.
Yeah, the cool factor wears off pretty quickly.
So, are there any other common misunderstandings or frustrations that maybe frequently come up? You just want to get out there, or anything we can do to address those things? I just want to make sure I cover all of our bases here. Any other things that you want to make sure that we know or do in the future?
I would like to talk about people that are interested in coming into the flight field.
Oh, yeah.
It's hard work. Yeah, it's a lot of hard work. And one thing that, I can say that we appreciate the least are people who are coming in just for the title.
Yeah.
Which I'm not going to say that specifically just for flight. That's any position, right? Somebody just wants to be a nurse because it's cute, or somebody wants to be a paramedic because you're going to be a badass and you're going to run out into people's houses and save them, that kind of thing. It's the same thing with any position. flight specifically, like if you're coming in with an attitude of whether you're a nurse or a paramedic talking to your opposite partner, right? Because I think that honestly, in a flight situation, a paramedic and a nurse are the perfect combination.
Mm-hmm.
When you have a great team, this is the perfect combination. This is a team that can get anything done. I truly believe that. With 2 paramedics, you can get a lot done. With 2 nurses, you can get a lot done. But with a paramedic and a nurse, you can fix just about anything. I had a gentleman that I was a partner with for a very short period of time who came in and was super excited, right, to be a flight nurse. And on one of the very first calls that we took, it was a head bleed. And I was like, look, this dude's GCS is pretty low. Like, there's a pretty good chance we're going to have to intubate when we get there. And one of the things that we have to consider when we're flying out to a location is whether or not we have enough oxygen on the bed. And to figure that out is by doing an oxygen consumption equation, right? So doing the math to make sure that you have enough oxygen for an intubated patient or a CPAP or a BiPAP or high flow nasal cannula, like whatever you're using at the time. And he was like, oh, okay, well, cool. Yeah, you do that. And I was like, oh, no, we're going to do it together because this is something that you need to know, right? I'm a very big proponent of, yes, we are a team. Yes, we're going to get this through. This is an amazing thing. But I also need to be self-sufficient in case I'm working with somebody who doesn't necessarily understand all the things because maybe they're new and they haven't learned all of these things yet, right? So I need to be able to take care of this patient by myself if I absolutely have to. And being told, no, thank you, that's what you're here for, is probably one of the most degrading things you can hear coming from a team member, right? No, you're new. You've had like 3 flights under your belt. Let's do this correctly. I hate that. That's like, I can go off quite a bit on that.
Understandably so. Like you had mentioned, both specialties, both expertise, both backgrounds bring so much value in the flight role. And for them to think like, oh, that's your job and I'm going to do my job, that is complete butterscotch, if you ask me. That is ridiculous. Like,
yes, it's incorrect.
Oh my gosh. Okay, so did you end up making them do the math or how did that go down?
I'm not into forcing anybody to do anything.
Okay.
If you do not want to learn, that's fine. I'm not going to teach you, right? I'm not going to force you to do anything. I will say he only flew like maybe a month. Like he didn't fly very long.
So maybe other people had the same feelings about his performance and attitude. Yeah.
I'm sure they did.
Yeah. What do you feel like are characteristics that make for a good flight nurse or a good flight medic?
Biggest thing is people who are always willing to learn, right? And then people who do well in a team setting. Maybe it's just the companies that I've been in, and maybe it's from coming from a ground background, right? Where you don't always have backup. But that's where I get that self-sufficient learning from. Like, I need to be able to take care of this patient if I don't have anybody else. And I've noticed that not a lot of other people have that idea or even sometimes have that capability. But being willing to learn through your partner, right? And then being willing to go and learn outside of work is going to make a really good person. Whether you're a flight medic or a flight nurse, you want to have all of those skills and all of that knowledge base coming into a critical care position. One of the things that I suggest, so there are minimums in most flight companies where the paramedic has worked at least 3 to 5 years in a like high or fast-paced community, right? High call volume. And then for nurses, they suggest 3 years either in the ICU or in the ER. I strongly suggest for nurses that are interested in getting into flight that you do sometime in the ER and sometime in the ICU because that addresses the emergency component and also the ability to titrate and monitor multiple drips at a time, because that's a skill that requires a lot of practice and a lot of thinking and a lot of med math. And if it's not something you're good at, it's hard to get good at in the heat of the moment while you're in an aircraft, bumping around, getting swayed around, and trying to deal with your patient and your partner at the same time.
That's good advice. Yeah. I mean, I would say this similar thing for rapid response nurses. People say like, oh, should I be an ER nurse and then be rapid response? Should I be an ICU nurse? I was like, dude, if you can swing both, that's going to make you the most well-rounded.
Yeah.
Because there are things that ER nurses are really, really good at that ICU nurses have never had to face.
Mm-hmm.
And there are things that ICU nurses are really, really good at. The ER nurses, even though they think they've had critical bases, they have never had a patient on 20 drips with tube feeds and a device stuck in some orifice that's keeping them alive. They've never had that. So there are just different things that make you great in those different environments. And if you can bring both to the table, that's awesome. Yeah, I agree with you.
Yeah.
But like you kind of mentioned, it's not just your clinical aptitude. There's a certain attitude and mentality that's required too, because you can be amazing clinically and suck as a partner, right? And you really need to be a good team player, a good partner. Gosh, one thing I was thinking about when I did all these ride-alongs is as a nurse, I work with new people every day. There's always a new team, a new concoction of who's the provider, who's the nurses, who's the nurse tech, who's the paramedics. I love that. In flight, they're telling me oh yeah, me and Joe, we've been partners for 10 years. We've worked every shift together for the last 10 years. I'm oh my gosh, you better like them. You better get along because you're stuck together for 24 hours in your station and then flying on a small helicopter. You better get along. Goodness gracious. But they were all telling me, yeah, and even outside of work, we hang out together, we barbecue together, our families go on vacations together. I'm well, dude, darn good that you like each other because it's really, really important to have a good partner. All the more important to have a good partner.
Yes.
Can you speak to that a little bit about how the partner relationship develops over time?
Yeah. But sometimes people don't get along, and that's okay too. Even if you don't get along with your partner, at least be professional and be courteous until you can get a different partner. I recognize that not everybody's going to get along all of the time. We're people, things bother us and irk us, and some days are worse than others. But again, be professional, be courteous, lift your partners up. Don't put anybody down. You'll get through it and you'll find another partner, or you'll get assigned another partner whenever they have the availability. It's not worth losing your job or leaving your job if it's something that you truly like doing.
Yeah, I agree. Well, Sam, I do want them to hear about your podcast, but before you tell them, is there anything else that you need us nurses to know about pre-hospital, interfacility transport, flight, nursing, or medic? Anything else that you feel we did not get to discuss today? I just want to make sure that we're thorough.
I just want to address the fact that there are not bathrooms in the airplanes or the aircrafts. Have a good bladder.
Start training now.
Yeah.
Start training your bladder now.
Shit happens, but hopefully not in the airplane.
Oh my gosh. I love it. I love it. That should be a bumper sticker. I'm just saying. Shit happens, but hopefully not in flight. Right. Okay. So I do want them to hear about your podcast, though. Can you just tell us the origin story? How did you end up developing this thing? What makes you want to keep going? Because it's a lot of work to have a podcast, and where can they find you?
Sure. So I'd always had the idea of, I really enjoy sitting down and talking with my coworkers at the end of shift or during shift or in the middle of shift or whatever. And I missed that feeling when I worked on the ambulance, because at the end of the day, you all get huddled into this tiny little room and you're all charting and you're sharing stories and you're having a great time and you're basically decompressing. And that's kind of how I wanted my podcast to be. I thought, I need to do this, right? Not just for everybody else, but also for me.
Yeah.
And that's how it generally got started. And then it went on from not just EMTs, but also to nurses and to doctors and respiratory therapists and other healthcare providers, including police officers, firefighters. Getting to interview everybody and anybody in the healthcare field has been really eye-opening. It's called 911 Nonsense, but it's not just for EMTs or paramedics. It's for everybody. Kind of the same thing. We already branded it.
Mm-hmm.
So some people feel a little intimidated coming and talking, but no, it's for everybody. We've been going for about 2 years now, and it's on everything you could look up podcast-wise. We're on Spotify and Apple Podcasts, YouTube. We just started a YouTube channel. We're just doing audio right now, but video hopefully in the future.
Gotcha.
We're on Instagram and Facebook.
That's awesome. Okay, so if they were to look it up, what do they actually type in?
So thank you. Great question. It actually has to be spelled out. There's no numbers in the name. So it's going to be NINE space ONE space ONE space nonsense. So 911 Nonsense.
Got it. And I will also put the link in the show notes so you don't have to remember that. I just wanted them to know if they were to have to find it somewhere else again. That's how it's 911 Nonsense. Awesome. It's a great podcast. You've had some really great guests on your show. I'm so glad that shows like this exist. People are always drawn to oh, you got to do the the deep dives in the pathophysiology, and those are important. They are important. But I think the heart behind what we do and how we process the hard stuff is equally important so we can keep doing the cool pathophysiology stuff. So yes, thank you for having these hard conversations and giving space for it and holding space for people as they're talking about their shifts. There's so much value there. Well, Sam, this has been a great podcast episode. Thank you so much for sharing your insights from the other side of healthcare. I think we all can benefit, like you said, from coming together for these patients and collaborating interdisciplinary, interdepartmentally. There's so much collaboration is the way to go. All right, Sam. Well, thank you so much for being on the show today.
Yes, it's been absolutely phenomenal.
Absolutely. Have a good rest of your day. Adios.
Thank you, Sarah. You too. Bye. Have a good day.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.